Hello everyone, I am Dr. Deepthi, Associate Professor of Pathology. Today's topic is on Hodgkin's lymphoma. Lymphoma means a malignancy arising from the lymphoid population of cells, and this presents as discrete masses arising from the lymph nodes, spleen or extranodal sites. That means mucosa associated lymphoid tissue. We have two types of lymphomas, Hodgkin's lymphoma and non-Hodgkin's lymphoma. So in this, we will see in detail about Hodgkin's lymphoma. The disease is named after Thomas Hodgkin, who first described this entity in 1832. So Hodgkin's lymphoma arises in a single node or a group of lymph nodes, and it usually spreads contiguously. And most of the times we see Hodgkin's lymphomas arising in the central or axial group of lymph nodes, that is the cervical and the mediastinal group. There is contiguous spread in case of Hodgkin's lymphoma and no contiguous spread in case of non-Hodgkin's lymphoma. And there is no extranodal tissue involvement in case of Hodgkin's lymphoma, and there is also no involvement of Waldeyer's ring or mesenteric nodes in case of Hodgkin's lymphoma. Hodgkin's lymphoma is characterized by presence of a giant cell called as Reed-Sternberg cell, also called as an RS cell, which is essential for its diagnosis. So the classical Reed-Sternberg cells are very large cells which are about 15 to 45 microns in diameter, and it has usually two or more lobes of nuclei having eosinophilic inclusion-like nucleoli. So a classical RS cell will have two nuclei which will have inclusion-like nucleoli inside them, and this will appear to us as owl eye appearance. So that is a classical RS cell normally we see in Hodgkin's lymphoma. Presence of an RS cell, there are also other differential diagnoses for it which we should be careful while diagnosing. So further, the different RS-like cells, the differential diagnosis for the presence of RS-like cells include mainly infectious mononucleosis, carcinomas, sarcomas, and immunoblastic type of non-Hodgkin's lymphoma. These four will be the differential diagnosis for RS-like cells. So there are different variants of Reed-Sternberg cells which we can see in different types of Hodgkin's lymphoma. So these are all the pictures showing different variants of a Reed-Sternberg cell. The first picture here is a mummified type of Reed-Sternberg cell, also called as a pleomorphic Reed-Sternberg cell. And this is a classic RS cell where we can see the nuclei which are mirror images to each other, also having an owl eye appearance. In this particular picture, we have the RS cells which are sitting inside a clear empty space. So this we call it as lacunar RS cells. So lacunar RS cells, why they appear like that? Because during the time of tissue processing, there is a retraction of the cytoplasm surrounding the RS cells, and that will create an empty space so that the nucleus will be sitting within a lacunae. That is one variant of RS cell, that is lacunar type of RS cell. And here we also have an RS cell which is called as lymphohistiocytic type of RS cell. It is a lymphohistiocytic type of RS cell, and here also we have RS cells which are having multiple nuclei. So these are all the different variants of a Hodgkin's lymphoma RS cells. Coming to the pathogenesis of Hodgkin's lymphoma, in most cases the RS cells are mainly derived from B cells. In that also the B cells mainly include post-germinal center B cell. Predominantly it is the post-germinal center B cells which are mainly the classical origin for a Hodgkin's lymphoma. In 1 to 2% of the cases, even there can be it can also be derived from T lymphocytes, but for us it is most important is it arises from the post-germinal center B cell. There is inappropriate activation of nuclear transcription factor NFKB, and this inappropriate activation of nuclear factor, that is transcription factor NFKB, occurs because of the Epstein-Barr virus infection. So Epstein-Barr virus on its surface has a product called as latent membrane protein 1, LMP1. This LMP1 will cause increased activation or upregulation of nuclear transcription factor, that is NFKB. Once there is activation of NFKB, then there is increased production of or increased proliferation of post-germinal center B cells in the form of RS cells. And this NFKB activation can also take place when there is a mutation which is involving CREL gene. The mutation involving the CREL gene that is present on the chromosome number 2 can also cause activation of NFKB in non-EBV associated Hodgkin's lymphomas. So whenever there is a production of RS cells, these RS cell, which is the main tumor cell. So in this Hodgkin's lymphoma, RS cells are the main predominant tumor cells. And these, once the RS cells are produced, they have the capacity to produce interleukin 4, interleukin 6, interleukin 13, tumor necrosis factor and GM-CSF. These are all the chemokines or the interleukins which are produced by the RS cells. Once these are produced, these will act as a attractants or chemokines and they will stimulate the accumulation of all the other inflammatory cells in the background. So always for the diagnosis of Hodgkin's lymphoma, along with the RS cells, we see all the types of inflammatory cells in the background. So the RS cells will be sitting in the background of polymorphous population of inflammatory cells, which contain lymphocytes, plasma cells, eosinophils, histiocytes, neutrophils, and stromal cells. So in this picture also, we can find plenty of RS cells which are sitting with the background of eosinophils, histiocytes. We can have lymphocytes and also the different types of other cells, even including the plasma cells. You can also see a plasma cell here. So this will be usually the picture of a Hodgkin's lymphoma. Coming to the classification of Hodgkin's lymphoma, we have two types: nodular lymphocytic predominant and classical Hodgkin's lymphoma. Among the classical, we have other types, that is nodular sclerosis type, lymphocytic rich, mixed cellularity and lymphocyte depletion. We have the four types under classical. So the important difference between a nodular lymphocytic predominant and the classical one is, here in the classical one, all the RS cells are CD15 positive and CD30 positive. They show the cluster differentiation molecule CD15 positive and CD13 positive. When coming to nodular lymphocytic predominant type, here the RS cells are CD15 negative, CD30 negative. These are CD45 positive, CD20 positive and BCL6 positive. So these will show cluster differentiation molecule CD45 and CD20 with BCL6 positivity, and in the classical form they show CD15 and CD30 positivity. So Hodgkin's lymphoma, usually it involves contiguous spread, and non-Hodgkin's lymphoma, it is discontiguous spread. 15 to 20% of all the lymphomas are Hodgkin's lymphomas, and predominantly the Hodgkin's lymphomas will have an age distribution which is bimodal. That means it usually starts between 10 years of age till 25 to 30 years of age, it can go to the peak, and after 45 years again there will be increased incidence. So you have two age groups where there can be an occurrence of Hodgkin's lymphoma. It starts from 10 years till goes till 30 years, and again after 40 years there is a risk of developing Hodgkin's lymphoma. And the disseminated disease where entire body will be involved is associated with night sweats and weight loss. So like any other malignancy, even Hodgkin's lymphoma can also result in weight loss. Rarely, this is considered as one of the paraneoplastic syndromes involving the Hodgkin's lymphoma. There can be pain of the involved lymph nodes on alcohol consumption. This is considered as one of the paraneoplastic syndromes, and the other one being secondary amyloidosis. Secondary amyloidosis. It is rarely extranodal, and usually we don't see any extranodal involvement in case of Hodgkin's lymphoma, and bone marrow involvement during the time of diagnosis is also very, very rare. And the Hodgkin's lymphoma, if it involves the spleen or the liver, it usually presents as a mass lesion rather than diffuse involvement. So this is the age incidence in Hodgkin's lymphoma and the non-Hodgkin's. You can see the red one where it increases from the age of 10 years and goes till 35 to 40 years and again comes down, and again the peak increases after 50 years. So there is a bimodal age peak. When it comes to a non-Hodgkin's lymphoma, again we can see that from after 40 years, that is from the 50 years, there is a rise or peak incidence arising for non-Hodgkin's lymphoma. So Hodgkin's and based on the types of Hodgkin's lymphoma, the relative frequency and the 5-year survival rate is as follows. So the most commonly lymphocytic predominant will have the most highest survival rate, and it will have a very good or excellent prognosis, followed by nodular sclerosis type. And lymphocytic depletion is almost very rare, and it will have a very, very low survival rate of only 20%. It will have a very, very low survival rate of only 20%. So it will be having a very poor prognosis. And nodular sclerosis type is the most common type of Hodgkin's lymphoma worldwide. When it is asked worldwide, yes, it is the most common lymphoma occurring worldwide, whereas mixed cellularity is most common in developing countries like India. So in India, the most common type is mixed cellularity, and in the world, it is nodular sclerosis type. Coming to the individual ones, lymphocytic predominant Hodgkin's lymphoma, it is relatively infrequent and mostly affects males less than 35 years of age. So there is nodular effacement of the nodal architecture. That means the entire node architecture will be effaced or changed. It will not follow the normal nodal architecture. And here the predominant cell what we see is LH cell, that is lymphohistiocytic RS cell, also called as a popcorn cell. We can appreciate the type of RS cell here, also called as a popcorn cell, and all the other cell types are usually absent and no fibrosis or necrosis is seen. Predominantly, as the word tells us, lymphocytic predominant, in the background we see plenty of lymphocytes along with the RS cells. So lymphocytic predominant, the origin is mainly from the follicular center B cell. That is why this type will express the B cell markers what we have discussed, that is CD20, CD45 and BCL6. This is CD15 and CD30 negative. This is not associated with Epstein-Barr virus infection. Disseminated disease is also very uncommon. 3 to 5% will evolve into diffuse large B cell lymphoma. This usually has a good prognosis compared to all the other types of Hodgkin's lymphoma, constituting about 90% of survival. Coming to the nodular sclerosis type. This is the most common type seen worldwide, with male to female ratio being same, and more common in women other than the other forms. And cervical, supraclavicular nodes as well as the mediastinum are initially involved. So it can involve mainly the central or axial group of lymph nodes, and we find the predominant cells called as lacunar cells. Lacunar cells, we have seen that they are sitting within an empty space. The nucleus is sitting inside an empty space, and the word nodular sclerosis will describe the lesion microscopically, where most of the cells are arranged in the form of nodules which are separated by this collagen fibrils. This pink one is all the collagen fibrils, and that is why it is called as sclerosis, nodular sclerosis. And within these nodules, if we see, we will have mixed pattern of cells in the background along with lacunar type of RS cells. And these lacunar type of RS cells will be positive for CD15 and CD30. They are positive for CD15 and CD30. So the 5-year survival rate is comparatively, when compared to other types of classical, it is little better with 80% survival rate. Mixed cellularity Hodgkin's lymphoma. Classical RS cells will be seen in case of mixed cellularity, along with, as the word tells you, mixed cellularity will contain all the inflammatory cells in the background. We can clearly appreciate the eosinophils. There will be increased plasma cells, lymphocytes, neutrophils, all in the mixed cellularity background with classical type of RS cells, which will have an appearance like that of owl eye. Frequently, these can also have systemic symptoms, like patient can present with fever, weight loss like that, and 20 to 25% of Hodgkin's lymphomas, these will be constituting, and these are more common in males. 70% of these are associated with Epstein-Barr virus, and these are also type of Hodgkin's lymphoma which are seen in case of HIV patients also. So good prognosis is seen, where the 50 to 60% of 5-year survival rate is seen. Lymphocytic depleted Hodgkin's lymphoma. Least common Hodgkin's lymphoma among all, and this is also having a very bad prognosis. This is also seen in older patients and also in immunocompromised patients, and it is often EBV positive. Abundant pleomorphic RS cells. We see abundant pleomorphic RS cells, where you can also see here, we can appreciate the cells here, where they show they are highly pleomorphic cells with few lymphocytes or diffuse fibrosis. So there will be only few lymphocytes, and that will again tell us that it has a poor prognosis. This usually have an advanced stage and systemic symptoms with a less favorable outcome. So among all the types, which is having the least prognosis or very bad outcome is lymphocytic depleted type. Coming to the next one, it is the lymphocytic rich classical Hodgkin's lymphoma, which is uncommon, and it is also more commonly seen in older males. And this also contains classical RS cells with large infiltrates of reactive lymphocytes. Lymphocytic rich, that again will tell the background contains predominantly more and more lymphocytes. This is also comes under classical type, so CD15 and CD30 are positive, and 40% of cases are EBV positive, Epstein-Barr virus positive. These also have a very good to excellent prognosis because they have a lymphocyte rich background. So those Hodgkin's lymphomas which have a rich background of lymphocytes usually will have a good prognosis, and those with lymphocytic depletion will have a bad prognosis. So this is a summary of all the 4 types. In this, the most commonly all the types are common in males except the nodular sclerosis type, where there is an equal ratio between males and females. Lymphocytic predominant is CD15 and 30 negative, and it is CD20 and CD45 positive. All the other 4 varieties are CD15 and CD30 positive. In nodular sclerosis, we see lacunar type of RS cells. In mixed cellularity, we see classical type of RS cells. In lymphocytic rich, we see classical type of RS cells with plenty of lymphocytes. In the lymphocytic depleted type, we see pleomorphic RS cells. And in the lymphocytic predominant type, we see popcorn type of RS cells. And similarly, among all these things, lymphocytic predominant type and lymphocytic rich type will have a very good prognosis, and lymphocytic depleted type usually has a very bad prognosis. And this lymphocytic depleted type is also most commonly seen in immunocompromised patients, and it usually presents with advanced disease. And nodular sclerosis type most commonly will have mediastinal involvement compared to all the other types. So Reed-Sternberg cell, as we already saw in the previous one, so CD15 and CD30 is usually positive if it is a classical variant of Reed-Sternberg cell, and CD45 is usually negative. But in case of lymphocytic predominant Hodgkin's lymphoma, we have more CD45 positivity, and CD15 and CD30 are usually negative. So an Orbital Staging classification of Hodgkin's lymphoma. Hodgkin's lymphoma and both the as well as non-Hodgkin's will follow the same staging, that is an Orbital staging. So stage 1 is involvement of a single lymph node region or a single extra lymphatic organ. So either extra lymphatic site or a single lymph node region should be involved in stage 1. Stage 2 is involvement 2 or more lymph nodes on the same side of the diaphragm, or localized involvement of an extra lymphatic site or organ of one or more lymph node regions on the same side. So same side of the diaphragm, if there is 2 or more lymphatic regions or extra lymphatic regions, that comes under stage 2. So involvement of lymphoid regions on both the sides of the diaphragm. If there is involvement of both extra lymphatic or the lymph nodal sites, if it is involving both the sides of the diaphragm, then it involves stage 3. Or even if there is involvement of the spleen, then also it comes under stage 3. Diffuse or disseminated involvement of one or more extra lymphatic sites or tissues with or without associated lymphoid enlargement, then comes under stage 4. So if there is a diffuse or disseminated disease, then it comes under stage 4. So the common risk factors which are associated with poor prognosis in case of Hodgkin's lymphoma. Bulky disease or involvement of more lymph nodes with bulky mediastinal involvement. If there is involvement of more than 3 nodal regions, then that is again associated with poor prognosis. Advanced stages. If the stage is more than 2B or more than 2B or 3, then it is associated with worst prognosis. B symptoms means the symptoms which are showing disseminated disease like fever, weight loss, etc. That is associated with very bad prognosis. Less than 70% response to 2 induction cycles after the starting of therapy, or during the time of diagnosis if the hemoglobin is less than 11 grams per deciliter, or ESR if it is more than 40 millimeters in the first hour. If there is a rise of total leukocyte count more than 12,000, or serum albumin levels if they are less than 3.5 gram per deciliter, or CD15 negative classical Hodgkin's lymphoma, if there is it's a classical one but it is showing CD15 negative, or nodular sclerosis type, or predominantly if it is seen in males. So all these factors play a very important role in the prognosis of the disease, and usually these will show poor prognosis if any of these are associated. Thank you so much.